Assalamu alaikum. I'm Dr. Sajadur Rahman, Associate Professor Pediatrics. So far, we have discussed different types of anemias, causes of anemias, anemias due to decreased production, anemias due to other causes. That includes increased destruction, hemolytic anemias. We discussed sickle cell and rest of the hemolytic anemias in children. One of the most important hemolytic anemias is thalassemia. We will discuss in details the thalassemia in this coming lecture. Basically, thalassemia is a heritable disorder. It is inherited from parents to children, and it's a type of hypochromic and microcytic type of anemia. Hypochromic with reduced hemoglobin in the red cells, and microcytic means that the cell is smaller as compared to the normal red blood cells. The mean corpuscular volume MCV is lower as compared to the normal. So it is basically hypochromic microcytic type of anemia and of varying degree of severity. Genetic defects basically which results in thalassemia. There is decreased or absent production of messenger RNA and globin chain synthesis. Basically, the defect is that there is reduced or absent globin chain production. There are 100 distinct type of mutations, and there is high incidence in Asia, Africa, Middle East, and Mediterranean countries. We will just review the basic physiology, as you already know what is hemoglobin, but we just quickly review hemoglobin structure. Each complex consists of 4 polypeptide chains, which are non-covalently bound, 2 alpha and 2 beta, 4 heme complexes with iron bound, and 4 oxygen binding capacity sites. This is the structure. Heme group attached to the beta chain, and here is the alpha chain, again beta chain and alpha chain, and 4 oxygens carrying sites. So this is iron, and basically it's responsible for carrying the oxygen. This is the structure of hemoglobin. So 4 subunits, 2 alpha, 2 beta, and iron, heme, and it binds 4 oxygen. So what is basically globin chain consists of, what are the globin chains basically? Globin chains are alpha globin chains, beta, delta, gamma, zeta globin chains. Alpha globin consists of 141 amino acids coded for on chromosome 16 found in normal adult hemoglobin A1 and A2. Alpha is present in normal adult hemoglobin. Beta globin chain consists of 146 amino acids coded for on chromosome 11 found in hemoglobin A1. So Then delta found in hemoglobin A2, small amounts in all adults, 2 to 2.5%. Gamma globin chain found in fetal hemoglobin, and zeta globin found in embryonic hemoglobin. So we will quickly go through all this thing. Hemoglobin types, basically hemoglobin A1, it's basically 92% of the normal hemoglobin is hemoglobin A1. It consists of alpha 2 and beta 2 chains, 2 beta and 2 alpha. Hemoglobin A2, it's 2.5% of the total hemoglobin, and 2 alpha and 2 delta. Hemoglobin F, it's less than 1% of the adult hemoglobin, 2 alpha and 2 gamma. Hemoglobin H, it's beta 4, 4 beta chains. Bart's hemoglobin, 4 delta chains. 4 gamma chains. Hemoglobin S, alpha 2, beta 2, and glutamic acid is replaced in place of valine. Hemoglobin C, alpha 2, beta 2, replaced by lysine. In place of glutamic acid, there is lysine. So all these are the types of hemoglobin. So what genetics involve? Alpha globins are coded on chromosome 16. We will not go into details. Also on chromosome 16, zeta globin genes are Gower hemoglobin also exist on 16 chromosome. Beta globins are coded on chromosome 11, and um, there is one gene on each chromosome, two genes in each diploid cell. Point mutation results in beta thalassemias. So it's important genetic. We should know the genetics. Also on chromosome 11 are delta hemoglobin A2 and gamma hemoglobin F and epsilon embryonic hemoglobin also. So this is the genetic structure of chromosomes showing different hemoglobin H, F, A2, and hemoglobin A. So what is alpha thalassemia? Basically, it results from gene deletions. One deletions, silent carrier. There are no symptoms, no clinical symptoms occurs if there is one alpha deletion. In two deletions, yes, alpha thalassemia trait, but anemia again, it's very minor, mild hypochromic microcytic anemia. Clinically, not that much evident. Three deletions results in hemoglobin H disease, and it's variable in severity, but less severe than beta thalassemia. Uh, most of the time, they don't need frequent transfusions. Four deletions mean, therefore, gene deletion results in Bart's hemoglobin. So, which is not compatible with life. Basically, death occur inside the uterus, hydrops fetalis, in utero, or early neonatal death. So, alpha thalassemia, usually no treatment indicated. 4 deletions are incompatible with life. So, 3 or fewer deletions have only mild anemias. So, you must know this was just to go through the because the most important one of the thalassemias is basically beta thalassemia. So, beta thalassemia, they results from point mutations on genes. Severity depends on where the heads lie. It could be beta naught. There is no production of beta globin chain. Absolutely no beta globin is produced. Beta plus means that there is reduced synthesis of beta globin chain. So, disease results in an overproduction of alpha globin chain, which precipitates in the cells and causes splenic sequestration of RBCs. So, basically, when there is no beta globin chain productions or reduced production, then there is overproduction of alpha globin chain, which results in precipitation in the cells and it causes splenic sequestration of RBCs. So RBCs are broken down there, and because they are not able to be deformed, they can't adjust the shapes while passing to the splenic uh, circulation, where they couldn't be deformed because of their internal precipitations and lead to sequestration and death and eruption. Erythropoiesis increases, sometimes become extramedullary because their oxygen carrying capacity is decreased. So basically, there is a natural tendency that hypoxia or anemia will lead to increased activation of erythropoietic cells, increase release of erythropoietin, and then erythropoiesis will increase because there is ineffective erythropoiesis, and uh, there is the red cells produce are not carrying the proper, not performing the proper function of carrying the oxygen. So there is overproduction and it results in extramedullary uh, production also, which leads to uh, again these typical thalassemic fascias because of these extramedullary production. Later in ages, it results in osteoporosis. So beta thalassemia, what are the clinical features of beta thalassemia? Beta thalassemia minor, in which there is minor mutation, minimal anemia, and no treatment is indicated. They are also called as carriers because they can carry the disease, they can transmit the disease, but they are not that much affected by the disease. And most of the time, they are diagnosed accidentally. Uh, they present with minimal anemia. Most of these patients receive multiple times iron supplements for their anemia. Uh, so it's a minor. Beta thalassemia intermedia, it's in between minor and major thalassemia. It is results from homozygous minor point mutation or more severe heterozygote. So it can be a spectrum. Most often do not require chronic transfusions. There can be hepatosplenomegaly to some extent, but not the, and most of the time the anemia appears in the second year or after that, and they most of the time not require that much chronic transfusions. So it's an intermediate form. Uh, Beta thalassemia major, it is also called as Cooley's anemia. There is severe gene mutations. So beta globin chain production is severely affected. It needs careful observation and intensive treatment. So now we will, what is the basically beta thalassemia major? It is reduce a non-existent production of beta globin. So poor oxygen carrying capacity of RBCs, agreed, failure to thrive, and poor brain development. It results in poor failure to thrive and poor brain development. And there is increased alpha globin production, and which leads to precipitation in the RBCs, and then RBCs are destroyed because of splenic sequestration, and RBC precursors are also destroyed within the bone marrow. So again, there is a destruction process in the bone marrow also. So increase again we have increased destruction of dysfunction RBCs, which results in anemia, jaundice, and splenomegaly. Hemolytic process is there, which results in all these symptoms. And then hyperplastic bone marrow. Bone marrow, as we already discussed, there is ineffective erythropoiesis. Whenever there is anemia, there is activation of erythropoietic activity. Erythropoietic activity in this case is that the bone marrow precursors are not producing normal hemoglobin because of genetic defects. So these RBCs even produced will not work that much and will not be effective in carrying the oxygen to the body tissues. So again, it is basically called as ineffective erythropoiesis. And RBC's precursors are destroyed inside the bone marrow, and there is poor bone growth and frontal bossing and bone pelvic. And as a result of that, also, there is medullary increase in extramedullary high erythropoiesis also starts. And then all these destruction of the RBCs and excessive erythropoiesis, uh, it leads to iron overload, increase because of increased absorption and transfusions. The body is having the capability or natural tendency that where there is deficiency of anything, the whole system, the whole uh, uh, body functions are diverted in overcoming that shortage. The basic purpose is to absorb, we have ineffective erythropoiesis, we need more iron. The body orders the intestines to increase the absorption of iron, retain more and more iron, and again, because of transfusions, there is also extra iron given to the body, and because of um, destruction of RBCs. So it leads to iron overload, and it's one of the key thing to keep in mind when managing the thalassemia major. That iron overload, most of the complications of thalassemia are because of this iron overload, and if you don't manage it, it leads to multiple uh, issues, uh, in which most common are that it affects your heart. It causes cardiomyopathy because the iron deposits there and causing cardiomyopathy. And again, in liver, causing liver failure, and it causes endocrine disorders, endocrinopathies. Especially, it leads to hypothyroidism and diabetes. Beta thalassemia major, what lab findings we could expect in that? Uh, you will see microcytic hypochromic, as I have already discussed. Peripheral smear will show target cells, nucleated RBCs, and isocytosis. Uh, basically, there is because of increased destruction of RBCs, it will result in reticulocytosis because it's a hemolytic process going on. Hemoglobin electrophoresis will show increased hemoglobin A2, delta globin production, and increased hemoglobin F, gamma globin production because of gamma globin production, and hyperbilirubinemia again because of hemolytic process. Um, Maybe you can have abnormal LFTs and thyroid functions, and then later on hypoglycemia because of iron overload. Thalassemia major, what is the treatment options? So it's a multidisciplinary approach is needed for the treatment of thalassemia major. It's a very vast subject. Now, days, just I will enumerate the most important treatment options available in Pakistan, and also I will enlighten you people regarding the what activities and what new researches are going on thalassemia for the treatment of thalassemia in the world. Mm, we need the first thing is the treatment of thalassemia. Whenever a patient is diagnosed, you need to screen out the whole family. It is an important issue in the management that you need to screen out both parents and the other sibs in order to rule out because if one family member is affected, it means there is because we know there is a genetic process going on. So and also advise them regarding if um, uh, other family members are affected, you will need to advise them according to their hemoglobin HB electrophoresis report. Secondly, you will advise the parents regarding the next pregnancy to screen for whenever they uh, have the next pregnancy. You will advise them to go for thalassemia screening. And if the screening turn out to be the baby turn out to be thalassemia major, so there is legal and Islamic provision that you can uh, uh, you can advise them abort the baby, but according to the gestational age of the baby. So it's again a specialized thing, but I would just like to mention that you should keep in mind that whenever you encounter a thalassemia major child, you need to advise them all. You need to manage the whole family, not only the single patient. So, because it's a very huge burden, both economically and mentally and socially on the family. So, what uh, you need to the major pillar is that you need to maintain the hemoglobin of the baby who is having thalassemia major between 10 to 12, because if you manage it between 10 to 12, you will postpone all the uh, you will improve the quality of life of the patient, you will improve the growth, you will improve the development, you will uh, avoid, you will suppress the extramedullary hematopoietic process uh, because and there is uh, in those children who are properly transfused, they don't develop that much thalassemia facies. They don't develop uh, large spleens and hepatosplenomegaly in which they in those babies who are properly transfused. So what is the optimum HB to maintain in case of thalassemia babies? It's 10 to 12. Uh, and the second treatment option is chelation therapy, because these children they are prone to iron overload, and you need to look into the iron, especially after 1 year of chronic transfusions. Uh, Or you check for ferritin levels, and if it's more than 100 nanogram per deciliter, go for the subcutaneous infusion of despheroxamine, and it's 5 nights per week, 8 hour subcutaneous infusion. What the chelation therapy do? It bind basically free iron and reduces hemosiderin deposits. So it's very important. And then we I will also let you know that now there are also development regarding chelation. We now have oral chelating agents, oral chelation agents also available in the market. What and then the third thing is splenectomy. Splenectomy. The reason why we go for splenectomy is that we want to reduce the cell destruction. And sometimes it becomes unavoidable if you want to save the life, because once spleen is violent in it, there is hypersplenism, and spleen is going to destroy all your RBCs and even all other cells, and causing sometimes severe anemia, even thrombocytopenia, and leukopenias also. So you need to go for the splenectomy, and other indications are that if transfusion required doubles, or it increased by 50% in 6 months, or our pure our red blood cells transfusion per year is more than 250 cc per kg. So all these are the indications of splenectomy. You need to vaccinate the child regarding against the encapsulated organism before going for splenectomy. Uh, Streptococcus pneumoniae, H. influenzae, and Neisseria meningitis. They are the common encapsulated organisms, uh, which are basically causing the infections in thalassemia. So they are prone to these organisms. So you need to also you need to vaccinate the children who are going for splenectomy, or they are suffering from thalassemia major. So again, because we are discussing the complications now, so sepsis, because of, as already I have discussed, because of encapsulated organisms, Streptococcus pneumoniae, Neisseria meningitis, H. influenzae. Cardiomyopathy it presents with congenital congestive heart failure. You need to give diuretic digoxin and spiroxamine. And endocrinopathies, you can have hypothyroidism, you can have diabetes, they present with diabetic ketoacidosis. So all these are the complications of thalassemia. Again, there is extramedullary hematopoiesis leading to frontal bossing, and this. Uh, Now we need to know about the anticipatory guidance and follow-ups. What you should look if a thalassemia patient follow your in clinics or OPDs. Immunizations, you look for, you go for immunizations status, you look for immunizations, if not immunized, go for hepatitis B and pneumococcal vaccine. Follow for signs of diabetes, hypothyroidism, gonadotrophin deficiency. Follow for signs of cardiomyopathy. Follow for signs of hepatic dysfunction because of iron overload. Osteoporosis prevention. It's more in adolescent children, more than 20 years or more than 18 years, 16 years. So you need to improve their diet, exercise, hormone supplementation, but in later stages. and ferritin levels. You need to check for the ferritin levels. So on the horizon, we have the uh, recent research. What's new in thalassemia? We have oral chelating agents now available in the market. Uh, Pharmacologically, they upregulating the gamma globin synthesis, increasing hemoglobin F. There are pharmacological agents which upregulate the gamma globin synthesis, uh, resulting in increasing hemoglobin F. And what hemoglobin F do is it carries oxygen better than hemoglobin A2 and will help bind alpha globins and decrease precipitates. So the third thing is bone marrow transplantation. Bone marrow transplantation is the key. That's the treatment uh, cure rather. It's the only treatment facility available. Again, in Pakistan, we have 2 to 3 centers doing it in government setups. We are doing it in Lahore and Karachi and Islamabad. PIMS Children Hospital have also started bone marrow transplantation. Few of the private sectors are also doing it. Then we have gene therapy. Gene therapy, um, you insert the healthy beta genes into the stem cells and it start producing normal normal RBCs. So it's in process. Uh, Gene therapy is the in trial phases. So if we succeeded, then it will be a major breakthrough. So it's all about thalassemias. Thank you so much.